everyone. The topic of my today's presentation is psychiatric manifestations of HIV. Introduction. HIV is a neurotropic and a neurovirulent virus. That is, it has the propensity to invade nervous system as well as cause pathological damage. Neuropsychiatric disorders arise from the direct effect of HIV on brain and the effect of secondary infections or tumor, the stress of living with HIV, and the medication used to treat HIV. Co-infection with hepatitis C is common in people with HIV. HCV can also cause neurocognitive impairment. Now, HIV and mental disorder, they have a vicious cycle, that is a bidirectional relationship. So, when the patient is depressed, he starts taking substance. There is cognitive impairment, demoralization. Then there is mental illness, which can lead to impulsivity. Again, substance use, cognitive impairment, and depression, which can lead to like impulsivity, or IV substance use, which can lead to AIDS. AIDS can again lead to depression, substance use, and cognitive impairment. Risk factor for developing HIV-related mental illness. There are medical factors and there are psychological factors. The medical factor is degree of CNS involvement, then the opportunistic infections, other medical conditions affecting brain and drug interactions. And the psychological factors include history of mental illness, change in quality of life, stigma associated with living with HIV, social support, and substance use. The prevalence of psychiatric conditions, the most common psychiatric condition associated with HIV is depression, then substance misuse, anxiety, then psychosis, adjustment disorders, and bipolar disorders. The differential diagnosis of psychiatric disorders in patient with HIV. What all can be differential diagnosis? A patient with a history of psychiatric disorder preceding HIV diagnosis, CNS HIV infections and lymphomas such as cytomegalovirus, encephalitis, cerebral toxoplasmosis, and cryptococcal meningitis. Then HIV-associated major neurocognitive decline, substance intoxication and withdrawal, neuropsychiatric implications of HCV infections and treatment, neuropsychiatric side effect of ART, and some endocrine abnormalities like hypogonadism, adrenal insufficiency, and thyroiditis. Now, first is delirium. Delirium is a state of global derangement. The prevalence in HIV patients is 43 to 65%. The clinical presentation in HIV is same as that of a non-HIV individual. So, what are the risk factors for a patient of risk factors for a patient of HIV to go in delirium is either there is HIV associated dementia, which is the first one to be ruled out. Then there is opioid and illicit substances, CNS infections and malignancies, sepsis, metabolic abnormalities, and HIV drugs that can also cause delirium. Now, the treatment includes identification and removal of the underlying cause, reorientation of the patient by maintaining diurnal variations of light cycle, providing orienting stimuli such as clocks, calendars, and active engagement of the family members, and management of behaviors and psychosis by low dose of high potency antipsychotics. Now, HIV-associated neurocognitive disorder, HAND. The risk factors for a HIV-associated neurocognitive factors include low CD4 cell count, that is less than 200 cells per microliter, high HIV viral load in CSF, age, female sex, methamphetamine use, family history of dementia, and co-infection with hepatitis C. So the HIV-associated neurocognitive decline is basically divided into three types: asymptomatic neurocognitive impairment, a mild neurocognitive disorder, and HIV-associated dementia. The mild neurocognitive disorder is basically a milder manifestation of the same symptoms seen in HIV and associated dementia, that is cognitive and motor slow. HIV-associated dementia. In ICD-10, it is classified under F02.4, that is dementia and human immunodeficiency virus disease included under organic mental disorders. It is a disorder characterized by cognitive deficits meeting the clinical diagnostic criteria for dementia in absence of concurrent illness or conditions other than HIV infection that could explain the finding. The prevalence is 15%. It is often multifactorial and involves both cortical and subcortical changes in brain. So the symptoms and signs include tremors, gait ataxia. There will be loss of fine motor movements, mental slowing, forgetfulness, poor concentration, and behavioral abnormalities. Now, the autopsy finding revealed of the patient with HIV revealed that there are characteristic white matter changes and demyelination, microglia nodules, multinucleated giant cells, perivascular infiltrate, but a marked absence of HIV within neurons. Thus, neuronal loss occurs through the action of macrophages and microglial cells, and through activation of cytokines and chemokines that trigger abnormal neuronal pruning. The best treatment is starting aggressive antiretroviral therapy, and zidovudine and efavirenz, they are themselves associated with potential significant neuropsychiatric complications which are used in AR. Now, HIV-related mood disorders. Depression, which is the most common psychiatric comorbidity among HIV-positive individuals. The prevalence is 37%, which is double of that of general population. Now, what are the risk factors? There are risk factors for HIV in depression. Then there are risk factors for depression in HIV. And there are some shared risk factors. So what are the risk factors that can lead to HIV? That is unprotected sex, multiple partners, and intravenous drug use. And what are the risk factors in HIV that can lead to depression is female sex, older age, elevated H1 RNA level, that is high viral load, homelessness, unemployment. That is, homelessness is poor social support, unemployment, poor income adequacy, active drug use, poor self-efficacy, and lack of social support. Now, there are some shared factors which can lead to like childhood abuse, cognitive behavioral factors, social relationships, suicidal ideations, personality profile like self-judgment, poor self-esteem, insecure attachment styles, and high neuroticism score. Now, there are two models for depression in HIV. One is biological and other is psychosocial model. So what is biological model is when the HIV infections, it invades the CNS cells. There is activation of hypothalamo-pituitary axis and sympathetic autonomic nervous system, due to which there will be activation of peripheral and central nervous system immune cells. Then there will be release of toxic viral protein. This toxic viral protein will lead to pro-inflammatory and inflammatory markers like TNF alpha, interferon gamma, interleukin 1 and interleukin 6, which will lead to altered pattern of basal ganglia activation. This increase in TNF alpha, interferon gamma, interleukin 1 and interleukin 6 will also lead to enzyme activation of an enzyme that breaks tryptophan, because of which there will not be the formation of serotonin, and there will be serotonin deficiency and reduced serotonin transmission. This increased TNF alpha, interferon gamma, interleukin 1 and 6 can lead to chronic sickness state behavior, weakness, reduced appetite, lethargy, psychomotor retardation, anhedonia, alteration in mood and cognition. Similarly, the psychosocial factors like functional disability impacting daily life, awareness of chronic disease, stigma of sex-related disease, need of strict adherence to ART, isolation, lack of support, discrimination, violence, and hopelessness and drug abuse, all this can also lead to depression. Now, the treatment, depression has a negative impact on adherence with medical treatment, quality of life, and treatment outcomes. Both antidepressants and antidepressant medications and psychotherapy is useful. The psychological management include counseling, cognitive behavior therapy, supportive psychotherapy, and interpersonal psychotherapy. Now, no antidepressant is ideal and must be tailored as per patient's need. Start low and go slow to minimize early side effect which may compromise the adherence. The hepatic metabolism of both psychotropic and antiretroviral drugs involve cytochrome P450 enzyme system, leading to multitude of pharmacokinetic interactions and serious adverse side effects. So the antiretroviral drugs, that is non-nucleoside reverse transcriptase inhibitors and protease inhibitors, they are both metabolized by cytochrome P450, and they are also enzyme inducers and inhibitors of cytochrome P450. So there are more chances of interaction with both these group of drugs, most notorious of which is ritonavir, which may be associated with most significant interactions. So Based on this, we can classify the antidepressants that we can give. So the antidepressants such as bupropion, venlafaxine, and mirtazapine, they are low cytochrome P450 blocker. They are less likely to have impact on metabolism of other drugs, so they have less interaction with other drugs. However, paroxetine, fluoxetine, and fluoxamine, uh, uh, these are low P450 blockers. यहाँ पे there is mistake. There are high P450 blockers. They are high likely to have impact on metabolism of other drugs. So these are less preferred. So mirtazapine has been shown to be efficacious for the treatment of depression in individuals with HIV because it is also beneficial for promoting weight gain for those with HIV wasting syndrome. Now, suicide and HIV. The suicidal ideas may affect almost 30% of the individuals, and these attempts tend to cluster in the first 6 months after the positive test result, and thus underlying the importance of pre-test and post-test counseling. So, with symptomatic AIDS, the percentage of completed suicides are 36 times more than non-HIV infected persons. Now, the risk factor for suicidal attempts are social stigma, withdrawal of family support, loss of friends and partners, long-term dependency, and prospect of an incurable illness. Then the next mood disorder is AIDS mania. It is associated with late stage of HIV infection. It is a consequence of a brain involvement. So there is progressive cognitive decline prior to the onset of mania. So irritable mood is characteristic. Other than that, there will be psychomotor slowing with cognitive slowing in AIDS mania. Of AIDS dementia will replace, in this mania, there will be psychomotor slowing and cognitive slowing rather than psychomotor excitation. There will be a lack of previous episodes or family history, and this will have a chronic course rather than an episodic course. AIDS mania patients typically respond to treatment with antipsychotic agents alone. For them, mood stabilizers are not needed. Late stage patients are far more sensitive to therapeutic effect, but even more to the toxic. So the patients in late stage of HIV, they are more sensitive to the toxic effect. So you should always start with a lower dose of antipsychotic. Then is schizophrenia. The schizophrenia prevalence rate is less, that is 4 to 19% only. So HIV doesn't directly lead to schizophrenia. But however, the schizophrenia can contribute to the behaviors that may lead to HIV infections. So the patient with schizophrenia may have high rate of unprotected sex, multiple sex partners, trading sex for money, and have sex while intoxicated. The patient with more positive symptoms and more impulsive behavior may be prone to high-risk sexual activities. Management employs antipsychotics for symptom control and psychological support and rehabilitation. Now the personality. The personality disorder, the prevalence is 19 to 36%. The most common personality is antisocial personality, which itself is a risk factor for HIV. This personality enhances their vulnerability to practice risk-taking behavior. The personality factors have implication for treatment like non-adherence to medication regimens. Anxiety disorders. People living with HIV can experience symptoms of anxiety across the spectrum of anxiety disorder. The most common is adjustment disorder. The prevalence is 2 to 40%. It is more in women. And acyclovir, antiretroviral like efavirenz, corticosteroids, isoniazid, interferon, interleukin-2, it can itself cause anxiety as a side effect. Now, the treatment is psychotherapy, which is relaxation and stress reduction techniques, and pharmacotherapy. For pharmacotherapy, we have to be vigilant with the drug interactions. So, in pharmacotherapy, we can give SSRI, we can give tricyclic antidepressants, and we can give benzodiazepines. So the benzodiazepines, alprazolam, midazolam, and diazepam, they are dependent on CYP3A4 for their metabolism. So potent inhibitors of CYP like ritonavir can lead to accumulation and over sedation, so should not be prescribed. However, oxazepam, lorazepam are metabolized by glucuronidation, so can be used with enzyme inhibitors. There is a term that is worried well. So those individuals who are intensely worried about being infected with HIV despite overwhelming evidence of the contrary. Their worried well status can progress quickly to generalized anxiety disorder, panic attack, obsessive compulsive disorder, and to hypochondriasis. Substance use disorder. Substance use is linked to multiple barriers in HIV care and outcomes. These include delays in HIV testing, entry into care, ART adherence, and retention in care. Also associated with secondary neuropsychiatric effects such as depression and neurocognitive disorders. So the treatment of substance abuse follow the same principle of care as for the person without HIV. It includes induction of patient role, then detoxification, then treatment of comorbid conditions, rehabilitation and relapse prevention. So acamprosate, disulfiram, and naltrexone. None of these medications have significant effect on CYP enzyme, and thus co-administration of these medications with ART is safe. Now there is pre-test and post-test counseling. So in pre-test counseling, we discuss the meaning of positive test and clarify the distortions, discuss meaning of negative result, discuss why this test is necessary, discuss patient's fear and concern, explore patient's potential reaction to positive result, discuss confidentiality issues relevant to testing, and discuss how positive result may affect the social life. Explore high-risk behavior and recommend risk reductions, document discussions, and allow patient time to ask questions. And in post-test counseling, there will be interpretation of test result, recommendation for prevention of transmission, recommendation for follow-up of sexual partners and needle contact. If result is positive, recommendation against donating blood, sperms, and organ, and give appropriate psychological support. And these are my references.